Good morning. I hope everyone is able to hear okay. I am going to be performing a voiceover of the content from Chapter 18, Nursing Care of the Child with an Alteration in Gas Exchange and Respiratory Disorder. Remember, this content can be found in your textbook, and as we're going through the material, if you need to stop, pause it at any point to clarify something or write it down, that ability has been enabled for you to do so. So without further ado, let's proceed. Okay, in looking at the anatomy of the respiratory system, which includes the nose, throat, and mouth, it's important that you're able to remember the function of the different elements, which are listed on this slide: mucous membranes, the salivary apparatus, taste buds, and nasal passages. If you look at the notes associated with this slide, I've provided some quick review, and I expect you to do that independently to make sure that you can recall what each of these organs' function is, so that you can be able to better understand the respiratory conditions that are affecting these parts of the body. It's also important that you understand what differs in the A&P of a child as opposed to an adult patient. So a couple of things to point out. The nose in kids, especially infants, they are typically nose breathers. So whenever there's any obstruction to their nasal passageway, it's going to make it difficult for them to have proper respiratory functioning. They don't realize that they can open their mouths to breathe. So in cases where they have a lot of mucus production, they're more susceptible to infections, and they're more likely to have distress. Newborns also have very small nasal passages, and their sinuses are not yet developed, which make them more prone to infection. In terms of the throat, we know that an infant's tongue is pretty large in relation to the rest of their oral cavity, and that tongue can result in airway obstruction. We also know that children have larger tonsils and adenoids, which, when enlarged or inflamed from illness, can also cause airway obstruction. And there's some illustrations you'll see throughout the PowerPoint slideshow that are just showing you the different parts of the respiratory tract. In this case, identifying the nasopharynx from the oropharynx from the laryngopharynx. And this way you can kind of see the way that everything passes and travels, as well as what parts are going to be affected depending on the condition or disease. And knowing that, like we talked about yesterday in the Zoom, is really important because it helps you to understand manifestations and management of care. Okay, continuing with pediatric differences, as I said previously, nasal breathers until about 6 months of age. Any edema and discharge that the child may experience can block the nasal passageway. In terms of the throat, the tonsils are normally large, especially in school-age children, and the adenoids can become enlarged as well, and this will cause bacteria to be accumulate and can interfere with their breathing. In terms of mouth and taste, sucking is very important for nutrition, and it is also influential in speech development, so it's important that children be evaluated for their ability to do so. Taste sensation is present at birth, but it continues to increase or improve during childhood. And dentition is another important element to the oral cavity of a child. We know that this develops gradually during childhood, and usually by the time the child's 6 months of age, their first tooth has erupted. By 2 years of age, usually children have all of their primary teeth, which is approximately 20 teeth, and around 5 or 6 years of age, they begin to lose their primary teeth. It's pretty much that. Okay, and continuing to review the anatomy and physiology of a pediatric patient versus an adult patient, want to just do a real simple recap, and you have this information on the notes, that there are two parts to the airway, the upper and the lower, and they're divided by the larynx. The upper includes the nasopharynx, oropharynx, and in most resources they would say the larynx is part of that. This is the pathway for air and gas exchange, where oxygen enters the lungs and carbon dioxide is removed from the lungs. And basically, this process we know to be ventilation. There's also the lower airway, which is the trachea, bronchi, and bronchioles. This pathway is where gases uh, flow from the alveoli of the lungs and alveolar sacs uh, disperse or diffuse oxygen across the membrane. We know that the intercostal muscles and diaphragm are used for the performance of breathing. We know that in order for effective gas exchange to occur, there has to be a balance of ventilation and perfusion, which is allowing oxygen-rich blood to get to all lung portions. And then you can also review some additional things like the mucosal lining and its function, surfactant, the respiratory center in the brain. All that is provided on this note slide just as an additional review of this information. Okay, looking at the pediatric versus adult airway in illustration form, you can see several differences in the structure, the placement, the size. And so make sure that you familiarize yourself with this information so that you can better answer the questions based on your understanding of what is unique about a pediatric airway. Okay. And again, just continuing to talk about how different the airways are between the adult and the child. The lower airway continues to proliferate. This means that the alveoli continue to increase in number, and this increase occurs up until puberty in a child. So, just for some point of reference, a full-term newborn has generally 25 million alveoli, but an adult has approximately 300 million. And these alveoli, as a reminder, are the smallest passageway in the respiratory system in which oxygen and carbon dioxide exchange can occur. So we know that children under the age of 6 are diaphragm breathers. They do have immature intercostal muscle. When a child's in distress, we see accessory muscle use as a telltale sign that the child is having difficulty breathing. It usually results in retractions, which are the sunken areas between the ribs, and this is supposed to be our indicator that the patient's having difficulty breathing. Uh, Different types of retractions can indicate the severity of the distress. We know that intercostal retractions are considered mild distress. They generally mean that the patient's compensating. When the patient exhibits substernal or subcostal retractions, that is an indication of moderate um, distress, and that it should be an indicator to take action, perform interventions, because it's becoming more and more difficult for the patient to compensate. And then lastly, the most severe indicator of severe distress is when retractions occur both supraclavicular or substernal. And it would be important to remember this breakdown of the different types of retractions and what they indicate as far as severity of distress. I love this illustration. And normally, if we'd be in class together, and if I had thought about it before I sat down, I would have a drinking straw in front of me and I would have handed one out to every student in the class. The purpose being a comparison. If you notice this airway illustrated, there's an A and a B. And what it's trying to show you is that the infant's airway is essentially the size of a drinking straw. If you think about what the diameter of a drinking straw is, that's a pretty narrow hole. A child's airway is not much bigger, generally the size of a person's pinky finger or little finger. And the illustration is trying to demonstrate that when a child already has such a narrow airway and then you add inflammation or edema on top of that, you can see how drastically it reduces the airway for that patient. And we'll talk about it again when we get to asthma further down the PowerPoint, but I would love to challenge you to take a minute, occlude your nose, hold your finger over your nose so that you're not breathing through your nose, and stick the straw in your mouth. Just, one of your fast food beverages straw in your mouth, and try breathing in and out through only the straw. not letting air escape around the straw, and not using your nose for airway. And see if you can tell that after a few minutes of that kind of breathing, it would be challenging, um, because it is such a small airway that you're using. And imagine if it was then occluded even further with inflammation and what the difficulty would be like to try to breathe. Okay, in the upcoming slides, we're going to talk about respiratory conditions, as well as nose and throat conditions, and we're going to differentiate between upper versus lower airway. So this illustration is not from your textbook. I don't think I found it on the internet, but its purpose is to show you that same division we discussed a moment ago in the A&P review, that helps you understand what is affecting, or what is included in the upper respiratory or upper airway and the lower airway. So just look at those illustrations to better understand that. And again, with the labeled illustration of the location of everything so that you can better understand what it's affecting in the body. Okay, so we're going to talk about some acute infectious disorders first. And there's a list on this slide. We're going to cover common cold, sinusitis, we'll talk about flu, we'll talk about pharyngitis, which is sore throat, and tonsillitis, as well as laryngitis. We'll discuss croup syndromes, RSV, and then briefly touch on pneumonia and bronchitis. So the common cold. The common cold is also referred to as an upper respiratory infection, or URI, and its medical terminology is nasopharyngitis because that's the portion of the body that's affected, the nasal passageway and the pharynx. So basically that tells us that it involves the nose and the throat, and it generally manifests as stuffy or runny nose, nasal discharge, and that can be thin, it could be thick, it could be clear, it could be discolored. It generally results in a sore throat, can make the patient hoarse. They tend to cough, and generally it's non-productive. Because of the drainage, they may have a loss of appetite. The patient may develop a fever. They may be more tired. They might even have like watery eyes, which is generally more of an allergy symptom associated with the common cold. With this condition, the most common treatment is going to be symptom relief. It's not medications, it's not generally antibiotics. It's more things like saline drops and a bulb syringe to suction the nasal drainage and open that passageway. It could include room humidification, which would be like a humidifier, which is developing or delivering moist air that can be breathed in. And then if there is a fever, we'd obviously want to respond with fever reducers if it's getting high or if it's becoming uncomfortable for the child. Next, we'll look at sinusitis. This is an inflammation or infection, usually bacterial in nature, of the paranasal sinuses. So it affects the inner connections between the nasal and respiratory tracts. It includes maxillary, ethmoid, and the frontal sinuses. You don't have to remember all of those names. I'm just trying to help you with kind of connecting the patho and A&P to this. This particular condition, sinusitis, is very common after an upper respiratory infection, which we just said was also known as the common cold or nasopharyngitis. In essence, it's a persistent cold. It's got very similar symptoms, usually heightened or more severe. Increased drainage, usually purulent in nature. Fever is generally higher. They may, express facial pain because of the location of those sinuses. When those are enlarged or inflamed, it's generally going to cause pain to those areas. They may have a headache, a cough that's persistent, complain of postnasal drip. Usually the breath is affected. So you think about kids or maybe even yourself when you wake up sometimes and you have that, like, it just tastes like or smells like a sickness breath. That's what we're talking about here. And it'll also tend to decrease the patient's appetite. You might notice lymph nodes are palpable, especially the ones located behind the ears. And then you may also see some effects to the eyelid, like some swelling, and the patient or child may be just irritable in general. Because it's usually bacterial in nature, we would venture to guess that antibiotics would be the treatment of choice. Um, if it's not bacterial, then obviously we have to let it resolve on its own. We may also recommend fever reducers, which would accomplish reduction of fever and help with the pain. And we need to continue with the same treatment measures we were talking about with the cold, which include the saline drops and bulb syringe, humidification, and increasing fluid intake. And we know that the increase in fluid intake is going to help with thinning the secretions so that we can expel them. Remember that anytime we are recommending antibiotics to a patient, we need to reinforce the need to complete them. I literally had this conversation with my 8-year-old this morning who told me, I don't feel bad anymore. I don't need to take this nasty pink stuff. And I said, son, yes, you do. Even though you don't feel bad anymore, if you want these oral medicines to work the next time you're sick, you have to finish this bottle. Because if not, I'll probably have to get you a shot for your next illness because these oral antibiotics won't do the trick. And he didn't like the answer, but it's very much the truth. And we need to make sure that we're encouraging the child and parents to follow through with that recommendation. Okay, next we're going to look at influenza, which hopefully is very familiar to all of you. In talking about influenza, we're just going to discuss, I guess, we're going to reiterate what's true of the adult patient also, but kind of make sure that you're thinking of it from a pediatric standpoint. So we know that with the flu, it's a viral infection, which means antibiotics are not going to be effective in treating it. It generally occurs during winter months when it gets colder. It is spread through inhalation of droplets or with contact of these fine particle aerosols. And the symptoms we most often see include fever, flushing and chills, headache, just a general malaise, cough, sore throat, nasal drainage, and complaints of body aches. Some children may experience other symptoms like a rash. They can have diarrhea. They can have what is considered a toxic appearance, which looks like they just look terrible. And they can have ocular symptoms also, like tearing, eye pain, or sensitivity. Um, Obviously, we know that, like we've had this season with COVID, that these conditions can have different levels of intensity or severity depending on the person and depending on their health overall and were they protected from the beginning. Like, did they get a flu vaccine? It might be milder than a patient or child that has not had that before. Our best recommendations for management include supportive and treatment of the symptoms. We want to ensure the patient remains hydrated. If the symptoms are detected and Tamiflu can be delivered within 24 to 48 hours of illness, then that might be a recommendation. Tamiflu is an antiviral drug recommended in kids and adults that can counteract some of the symptoms or keep it from getting worse, but it is time sensitive, so it would need to be detected and administered within a day or two of illness. We also want to recommend the vaccination for the flu. Yearly is available generally starting in September and through, April or May of the following year for that flu season, and it can be given to children as young as 6 months of age. So we want to make sure that we're advocating for this protection, which even if it doesn't keep the person from getting the flu, it can significantly reduce their symptoms. Pharyngitis, aka sore throat, or what's popularly known as strep throat. In order to know if it's strep, you would have to perform a strep test. That's the only way to determine definitively that it's streptococcal in nature. Pharyngitis can be viral. This infection affects the tonsils, and in any case, you would have to look at blood count to try to determine viral versus bacterial nature, as well as culture for strep to see if it tests positive to that. It's basically inflammation of the pharynx or throat. If it's viral, it usually is accompanied by nasal symptoms. So if they're having a lot of nasal, drainage or congestion in addition, then it's likely viral. If that's not present, it's likely bacterial. It can have a very abrupt onset. You can go to bed or even have a child lay down for like a nap and then wake up with all of these symptoms manifesting. Throat redness, pain, swelling. There can be white patches on the throat, drainage. Children usually have fevers, and usually it's high. Their lymph nodes can be enlarged and palpable. There can be complaints of it being difficult to swallow. They may say they have a headache. They may say it's upset in their stomach with abdominal pain. And they're also likely to have a rash. And it's usually fine red sandpaper-like rash that is associated with strep form of pharyngitis. For treatment, if we have determined that it is streptococcal, then antibiotics can be administered. If it's generally bacterial, things like penicillin, azithromycin, clarithromycin would be the drugs of choice. If it's viral in nature, then it's going to be more symptom management. In either case, we want to encourage saltwater gargles, cool fluids for the hydration and to help provide some comfort, pain and fever reducers, and also humidification for helping to just moisturize the airway so that it's not as uncomfortable. Tonsillitis and adenoiditis. This and strep throat or pharyngitis often get misdiagnosed or they're used interchangeably, but they are different. Tonsillitis and adenoiditis is inflammation of strictly the tonsils and the adenoids. It too can be viral or bacterial in nature. It is often manifested by inflammation to both the tonsils and adenoids, but it can happen independently. Uh, the patient will complain of difficulty swallowing, maybe even affecting their breathing. Their throat, the tonsils will be red, enlarged. They will complain of pain. They may have the palpable enlarged lymph nodes. Their mouth in general may be dry, and they generally have a hoarse voice. So our recommendations for treatment are supportive unless it's bacterial, in which case we can also prescribe antibiotics. As the nurse, we want to encourage completion of antibiotics if taken, and if this is happening on a recurring basis for a child, then they may need a referral to an ENT for possible TNA, which stands for tonsil and adenoid removal. In the event of surgery, we'd have to obviously educate on pre and post-op care. As mentioned, antibiotic therapy would not be part of the treatment unless there is a definitive bacterial origin to the illness. Diagnosis is generally looking at it from the standpoint of a sore throat plus at least one other symptom, and that could be the fever that's above 101 degrees, adenoid swelling, exudate, which is the accumulation of drainage or pus on the adenoids or tonsils, and a positive strep test could also be your additional symptom. And as previously stated, a tonsillectomy is often recommended when children are having recurrent throat infections. They have what's considered chronic tonsillitis, or they may even be having obstructive sleep apnea, where they're having trouble breathing while they sleep. And you won't be tested on this, but just information for you. 7 episodes of tonsillitis in a year, 5 episodes per year for 2 years in a row, or 3 episodes per year for 3 years in a row would all be grounds for getting them removed. I'm sorry. My dog has come to check on us, so meet Alex Parker. Thank you. Yeah, thank you. Okay, you're gonna have to sit down or something. Oh man. Okay, next slide. Okay, and just to give a little more information, if we do have a patient who is requiring tonsillectomy. Know that post-surgery, the child would need to be placed in a side-lying or prone position. This is to promote airway clearance. Um, we need to monitor for distress in terms of respiratory functioning, and we need to especially monitor for, oh my gosh, Alex, stop. Oh man, you're kind of on the way. Okay, we need to also monitor for bleeding or hemorrhage. The child will be prohibited from taking any NSAIDs like ibuprofen for 10 days to 2 weeks prior to surgery and immediately following. If a child is displaying a lot of increased swallowing, that could be an indicator of excessive bleeding. So we need to, get that checked on. We need to encourage fluid volume, avoiding things like citrus or brown or red fluids because that can be confused as bleeding. We need to encourage analgesics and maybe even like an ice collar, which is basically like an ice pack placed around the neck so that they can relieve their pain. And we need to discourage, if at all possible, coughing, blowing their nose, or drinking through a straw, all of which can aggravate the incision and result in increased bleeding. Okay, looking at mono. Mono is a condition that you'll learn about in respiratory in terms of an adult patient as well. This one is most often remembered because it's associated with the Epstein-Barr virus. Symptoms of mono include fever, a general feeling of malaise, sore throat, and lymph node enlargement. You may have heard of it as the kissing disease because it is generally spread by oral secretions. It is most common in adolescents and young adults, and the symptoms you would notice include fever, sore throat, tonsils having like a gray pus or exudate to it, and then can also result in a rash. Um, I've even seen patients that have a report of jaundice associated with mono, so that would definitely need to be discussed and looked at. If it becomes as severe as to result in enlargement of the patient's spleen or liver, then you'd have to avoid any strenuous activity and contact sports until those organs resume their normal size. And this would be happening because of the Epstein-Barr origin of the illness. Our care for the patient would be symptomatic saltwater gargles, analgesics, lots of bed rest, and maybe some corticosteroids to help improve, how they're feeling and reduce the discomfort. Laryngitis. No notes on this one. Everything that's important to know is right there on the slide. It is the least serious form of any kind of respiratory illness in children. It is generally viral or only viral. It involves inflammation of the larynx, which is where your voice box is. So what it most often does is result in a hoarse or loss of your voice altogether. It comes on abruptly. You can wake up with it the next morning having no signs of it the night before. It often affects infants and toddlers. It often goes away on its own rather quickly, and the management for it is supportive oral fluids and rest. There is generally no fever and no pain associated with laryngitis. Okay, croup. Croup is a really important one, and I think, if I remember correctly, we'll spend a little time on this with a slide or two. Croup's medical name is a mouthful, laryngotracheobronchitis, and if you break it down, it's the parts of the airway that are affected: larynx, trachea, and bronchi. This particular virus is self-limited, which means that it generally resolves itself. It is viral in nature, and it most often affects children that are 3 months to 3 years. So remember 3 months to 3 years of age. The symptoms are most often present at night, and they include inspiratory stridor. Remember, stridor is that sound that is very concerning when we hear it. It just sounds like they're having trouble breathing, and something is occluding the airway and air is escaping around it. And it's always a sign that intervention needs to be performed quickly. They may also exhibit a seal-like barking cough. They can become hoarse. They may have retractions, usually suprasternal in nature, and they may have a lot of mucus production. Uh, these symptoms obviously make sense based on what we know is happening, which is the airway becoming inflamed and swollen and causing obstruction. Usually it resolves in 3 to 5 days. There's your number 3 again. And only in situations where it's very severe would the child have to be hospitalized. If you think back to nursing years ago, you may have heard of a croup tent. That was a thing in hospitals that children were placed in to basically keep the air in the room moist and humidified, and it was helping to improve their symptoms. Nowadays, it's not practiced very often, or at least not locally, but in the event of a severe case, it might be needed. Other interventions include corticosteroids. They may need racemic epi, which is essentially nebulized epinephrine. They will need humidification, increased fluid intake, and rest. They need to stay in an upright position, which maximizes lung expansion, and be provided a quiet environment. So, okay, so this particular condition, epiglottitis, which is epiglottis with the itis inflammation associated with it, is similar to croup in its um, initial symptoms, but it's a more severe form of it, like way more severe. When this condition is brought up, you should be thinking like, rapid response kind of thing, because it can result in a decline of the patient very quickly. It progresses within hours, and it can lead to a completely obstructed airway, which I believe I've included an image on the next slide. It is life-threatening. It is bacterial, which is good because we know that we can give an antibiotic that will improve it. The problem is we don't know which bacteria is causing it until we perform a culture. And usually that takes some time. So I talked about it a little bit yesterday in our Zoom, just as an example, that we would have to make sure the patient's airway is established before trying to get, say, a culture on the patient, which would, potentially cause more obstruction because that mechanism of trying to swab the throat is going to want to make the airway close further. It affects toddlers through school-age children. It's rapid in onset and progression. I mentioned within hours. It's normally accompanied by a very high fever and the D's, and there's 4 of them. So make sure you understand what these mean, as well as remember what they are. So dysphagia, which is the difficulty swallowing, drooling. I don't think I need to define that one. Dysphonia, which is a distorted or muffled voice, and distress, which is in reference to breathing. So those 4 Ds would be things to consider. Typically there's an absence of cough because it's so obstructed that they can't even form a coughing effort. They may have increased vital signs, including blood pressure and heart rate associated with their discomfort and anxiety. They may have the toxic appearance that's common with conditions like shock, where they have an overall ill look to them, pale, labored, and their epiglottis is cherry red in color. There's an illustration to come of the tripod posture. This is the child who's got their hands on their knees and their neck extended, and that is an effort to, suck in air. They are trying very hard to perform effective breaths. This child would tell you, I don't want to lie down. And what's most important in this situation is to allow the child to stay in whatever position is most comfortable for them and provides the best breathing for them. This is an emergency airway protocol, which means 100% oxygen. But like we talked about yesterday, what good is it if I'm putting oxygen on the patient if the airway is completely obstructed and I can't let the airway actually receive the oxygen. So we also need to be preparing for intubation. Child could even require a tracheostomy depending on the severity. And our role as nurses would be to gather the equipment. Once the airway is established, they would need a culture to determine what kind of bacteria it is, and the patient would be receiving IV antibiotics and fluids, humidified oxygen, and likely some comfort and support, both emotional and psychosocial. Parents are going to be panicking in this situation, so we also need to provide some answers and comfort for the parent as we're able. Um, just to let you know, the most common group of children, that toddlers through school age, specifically 2 years through 7 years, it's children that didn't have the HIB series of vaccines. So that HIB, Haemophilus influenza B series is a series that's given from birth through like 15 months of age. Children without that are the ones that are most prone to epiglottitis. Another reason vaccines are so important. And as I mentioned, it's a severe form of croup, so it does have the croup-like symptoms: inspiratory stridor, still-like barking, cough, hoarseness, but it's usually more severe, and sometimes it can, have no cough at all. It's absent because of the level of obstruction. Just as an additional explanation of the tripod posture, the child sitting up, leaning forward, palms on knees, jaw thrusted forward, and they are essentially like they're sniffing. If you think of a dog that reaches out its neck to sniff something, it's trying to determine if it's, safe to approach. Same concept. The child has got that position, nose pointed at the air, trying to take in air. Child will not lie down. This is considered the classic sign of the condition, and we've discussed what would be important as far as interventions. Obviously, in terms of the quiet environment and also minimal anxiety provoking. So procedures like IV start that are going to be painful, even the swabbing that are going to upset the child, need to wait to be performed once the airway is secure. Okay, this is the pictures. This is the little boy on the right in the tripod posture, and the little girl on the left showing you the anatomy of epiglottitis. Uh, Do's and don'ts of epiglottitis: do not attempt to visualize the throat. Do not leave the child unattended. Do not place the child in a supine position. Provide oxygen 100% in the least invasive manner so that anxiety is reduced. If complete airway occlusion occurs, know that tracheostomy may be necessary, and ensure emergency equipment is available at all times. All right, so that was all of your upper airway disorders, nose, throat, and beyond. Now we're going to be looking at your lower airway disorders. And if you remember back to the illustrations at the beginning of the PowerPoint, they were intended to help differentiate so that you could easily see like what part anatomy wise is being affected, and that will help you to think about manifestations and management of care. So these disorders will include the bronchial tree, which is bronchi, bronchioles, and alveoli. And so we'll specifically be looking at bronchiolitis, which is RSV, bronchitis, and pneumonia. Pneumonia's got an asterisk because I don't go in depth on it since it's an adult condition as well, but I do point out how it differs in kids. Here's your lower airway illustrations again, showing you where everything is located. Okay, and we're going to start with a just general overview of the manifestations that are most common in lower airway disorders. And I've broken it down into infants versus children and adolescents. This came from the previous text we used. It was a great resource. This text did not include, and so we brought it over from that publisher so that y'all would have this information. So, most common clinical manifestations of lower airway disorders in infants: nasal flaring, retractions, grunting sound, irritability, and tachypnea, which is that elevated or rapid breathing rate. In children and adolescents, the most common things you're going to see when lower airway disorders are present include crackles, labored breathing or dyspnea, wheezing, cyanosis, and it can vary in severity, and then cough, which we see often like in bronchitis, pneumonia, and TB. So the first we're going to look at is bronchiolitis. And you notice it says in the first bullet, often RSV, which is viral. Just have to point out that it's not always RSV. RSV stands for rectosynovial virus. It's a particular virus strain. But 70% of cases, it is RSV. So we have to recognize that it can be caused by other viruses or combinations of virus, but the one that we're talking about in terms of the PowerPoint and the textbook is RSV. That's what we're associating with bronchiolitis for purposes of this text. It is inflammation or obstruction of the bronchioles, which are the smaller airways that stem off the bronchi. It has got a season to it, and it is generally winter to spring. So it starts around September and it persists through April or May. It affects infants and toddlers most of all, and it can occur or be spread from direct or indirect contact. Children with RSV generally have rhinitis, which is the runny nose, low-grade fever. They may be coughing. They may be a poor feeder, rapid breathing, and wheezing if it's a mild form. That's, a good scenario. They also have severe forms of bronchiolitis or RSV. And in that case, you're going to notice things like an air hungry appearance, cyanosis, retractions. They may have the accessory muscle use. They will be grunting. They would be having some apneic spells. They may be lethargic, dehydrated, and have some diminished breathing. So it's important that we be able to differentiate the severity of this symptoms. All of these manifestations are occurring due to swelling of the airway lining and excessive mucus production. So when you're thinking about what you would expect to see, think about what's happening. Swelling of the airway and excess mucus production. Their airway can be partially obstructed. It can result in bronchospasms. These children, they just appear sick. They're not playful. They don't really care about eating. If they do eat, they may spit up or maybe seem like they're having some vomiting after, and that's because of the mucus. When you listen to them, their lungs are noisy. And really the truth with the RSV is the noisier the lungs, the better. Because if their lungs are noisy, then that means that they're still able to move air in and out of the lungs. When we get a patient with diminished breath sounds, that means that their airflow is decreased, and that should be a red flag for you. Yeah, yeah. Most children have been infected at some point. RSV is very common. But the reason it's being discussed here, and you may have heard of it as a concern, is that it's most severe in certain populations, more vulnerable infants and children. It's usually children that are premature or have other issues like heart defects or lung conditions. So we'll talk about that group of patients in just a minute. Our treatment for this is going to be supportive since it's generally viral in nature. Antibiotics are not going to help. I don't discuss it much, but bronchiolitis can be bacterial. That is a thing, but it's in very few cases, in which case antibiotics would be helpful, but that's not the type we're discussing here. For purposes of a test question, in our textbook, we're talking about the viral form. So treatment would be supportive: oxygen, fluids, medication, humidified air, hydration, could be oral or IV depending on their cooperation, suctioning to remove some of that excess mucus. In severe cases, they may require a CPAP machine, and they may require medicines such as nebulized form of epinephrine or corticosteroids. These children may be put on bronchodilators. Beta-2 agonists and anticholinergics can be beneficial. You don't have to remember specifically what types, just know bronchodilators. But just to give you some examples of names, we're talking about things like albuterol and Zopinex. That's examples of short-acting beta-2 agonist, and Atrovent would be an example of an anticholinergic. They may just receive nebulized saline, no medicine in it, just saline. They may need fever reducers. If hospitalization is required, these patients are going to be isolated and they may be placed on droplet precautions. And usually the condition resolves in a week, 5 to 7 days. But the worst part about RSV for a parent to understand and expect is that it generally gets worse before it gets better. So a patient may be symptomatic on day 1, be seen and diagnosed and told it's viral, have to run its course, and by day 3, they're in a lot worse condition than they were on the first day. That is the typical progression, and parents need to know that up front. Once they get over that hump, then it usually tends to get better. Synagis is a prophylactic injection. I'll probably mistakenly say vaccine at some point, but it's technically not a vaccine. And there's a science explaining that, which I'm not testing you on, but just know that Synagis is the prophylactic injection that's given intramuscular to children in the high risk category. So basically those vulnerable patients I mentioned before that are premature and have heart defects or lung conditions, they may be candidates for this injection, which is given every month during RSV season, which is that September through April or May timeframe. The child gets a weight-based dose every month during RSV season. Know that it's a very expensive treatment, which is why not everyone gets it. It can't be administered to all children, only the vulnerable population because of the expense of the drug. And so also know that the criteria for coverage has changed over the years. So kids who used to get approved, my son was approved at birth because he was premature and he had a heart murmur, and likely asthma, but at the time that was too young to be diagnosed. His conditions would no longer meet criteria. They've drastically changed the criteria, I guess, as a cost effectiveness because it's such an expensive vaccine. So there might be a test question that says something about Synagis prophylactic for patients or Synagis as a treatment for patients. It's not for everyone, and it's not beneficial after the patient's symptomatic. It only works if it's given preventatively, month after month, and hopefully it reduces the chance of getting the condition or at least makes it milder in form. Okay, looking at bronchitis now. Bronchitis is usually in conjunction with other respiratory illnesses and adjacent respiratory structures. So you'll see as the slide depicts that it's inflammation of the trachea and bronchi, but it tends to occur in other places too. It's usually not an isolated condition. It's most often diagnosed in the winter. Its telltale symptom or sign is a dry, hacking cough that's worse at night. The patient may complain of pain in their chest or in their ribs. Their breath sounds will be coarse, and they typically need things like cough suppressants. I'm sorry, just totally blanked. We want to discourage the use of cough suppressants. They may think they need that because of the severity of their cough, but the purpose of not suppressing it is that we want them to cough the sputum up. We want them to clear the body of this infection. And if we suppress that cough, then we're actually keeping that infection inside. So this cough can be productive or it may be non-productive, and it can also be associated with vomiting up some sputum because of the mucus production. Oftentimes, their coarse breath sounds will begin as fine crackles and progress to wheezing. We want to perform palliative care, which is treating symptoms and making the patient comfortable. If it does result in a secondary bacterial infection, then we can obviously treat that with antibiotics. Okay, pneumonia. Very minimal information on the slide itself, but some stuff in the notes that I want you to look at. Why did it just skip? Okay, well, I don't know why we can't return to the pneumonia slide. It just disappeared on me. Go read that slide, please. Basically, just need to know that it's very similar to the presentation that you see in an adult patient with minimal differences. And those differences I don't have in front of me. So, yeah, I do. Hang on. Just give me a second. Pneumonia. Okay, so things to know about pneumonia. This is not that slide. You obviously have to go back to that. The child's age, severity of symptoms, and presence of underlying disease is usually what determines the variation in manifestations as well as care of pneumonia in kids. Viral is more common in children that are younger than 5. So if you have a kid infant through 5 years, they're likely experiencing viral pneumonia, which means they have to just let it run its course. Bacterial is more common in children 5 years of age and older. Usually pneumonia follows an upper respiratory infection or URI, and it can have non-infectious causes, which means it's not from a virus or bacteria. And hopefully you're thinking what I'm about to say, which is aspiration pneumonia, which means that you're drinking something or chewing something and you aspirate, and that turns into pneumonia. So that would be an example of a non-infectious source. Manifestations are the same for other lower airway disorders. So you go back to those that slide that had the breakdown of infant versus children and adolescent lower airway manifestations, and that's what you're going to see in this condition. Treatment's going to be symptomatic and supportive. If it's bacterial, it'll include antibiotics, fever reducers, lots of rest. In severe cases, they may need to be hospitalized and receive IV fluids and oxygen. The nursing care, the measures you're going to perform generally are the same for the child with bronchiolitis or RSV. We want to encourage compliance with the immunization schedule because HIB, that Haemophilus influenza B, and PCV13, which is the pneumococcal vaccine Prevnar, those are proven to reduce occurrence of pneumonia in children. So if a child's being vaccinated appropriately with things like HIB and pneumococcal, then generally they're less likely to have pneumonia in childhood. Okay, sorry for that slide dilemma. Now we're on tuberculosis. Tuberculosis is highly contagious. It is caused by inhalation of droplets of the Mycobacterium TB. It has a 2 to 10 week incubation period. And symptoms for TB include fever, malaise, that general ill feeling, weight loss, anorexia, pain, and tightness in the chest. One very important thing to know, when you think of TB, you probably think of coughing up blood. But in children, this is really the case. Rarely results in coughing up blood in kids the way it does in adults. The treatment for it is a 6-month regimen of oral therapy and supportive care. And the oral therapy or medications generally include isoniazid, rifampin, and pyrazinamide. So you can try to remember this little cocktail of 3 drugs. I don't think I'll get too tricky with it on the test, but it is important to know that a regimen of 6 months of these medications are generally needed for treatment. And as a recap, when we have respiratory conditions that are acute in nature, our nursing care will be to determine the child's baseline, provide support, encourage fluids and nutrition. We want them to have an intake that meets their increased metabolic demands. Also, because they're going to be having insensible water losses, these children are going to need more calories and fluids during an acute illness. We want to relieve anxiety. Uh, Anxiety is going to cause an increase in oxygen need, and it can impact the respiratory system negatively. So we want to reduce that. Provide education and discharge planning. Assess the learning needs, the teaching needs of the patient and their family. These children may require home therapies, so we need to give that information as well. And we need to make sure they understand that not all symptoms will resolve right away. So it may take days or weeks for some of these symptoms to clear. Okay, now we're going to look at some acute respiratory disorders that are non-infectious. So these don't have any bacterial or viral origin. Okay, and just to see on the slide, that'll include epistaxis, which is nosebleed, FBA, foreign body aspiration, RDS, respiratory distress syndrome, ARDS, which is acute respiratory distress syndrome, and pneumothorax. Epistaxis, very easy. No additional information than what's on the slide. It's a medical term for nosebleeds. It occurs in school-age children. It's most often noticed in males. And our recommendation of management for a child is to have them tilt their head forward, pinch their nose, and apply ice or packing if needed. This is going to result in vasoconstriction, which is what we want so that it doesn't continue to bleed. So remember those couple things and you'll be fine on that. FBA, foreign body aspiration, which may also be referred to in literature as FBO, which is foreign body obstruction. This can occur from inhalation or swallowing. If it's inhaled, it's usually going to be in the nose. If it's swallowed, it's usually going to be in the throat. Where do aspirated foreign bodies most often end up? That would be the bronchi. Generally, it's the right lung, and it's due to the physiology of the lung. It has a sloped angle. Know that if it ends up in the trachea, it can be very life-threatening. The substance is inhaled into the respiratory tract. It most often involves infants and young children who don't know any better. Know that if an object can fit through a toilet paper roll, it can be aspirated. So think about your empty toilet paper roll. If we were in class, I'd have one with me. I should have brought it from the bathroom. But just imagine a toilet paper roll about yay wide in diameter. Trying to get my hand to look at you correctly. Okay. If it can fit through that, it can be aspirated, which is a hard concept to think of. So we need to be very careful with what we have out and available for kids to play with so that we're not risking this occurring. Generally, it's manifested by a sudden onset in cough, wheeze, or stridor. The symptoms will get worse as the object travels further into the respiratory tract. Prevention is the most important intervention, and our management should be maintaining a patent airway, reducing anxiety, and removing the object. That may involve back blows and chest abdominal thrust or Heimlich, depending on the child's age and size. Generally, the location of the airway obstruction can be narrowed down by the sound and signs that the child's displaying. So, how they sound and what they're doing is generally an indication of where at in the body that object has made it to. Also, your manifestations are going to depend on the location, in turn, of where the object is. Know that the same symptoms associated with respiratory distress or compromise or what we see in other conditions are going to happen here. Sometimes the symptoms can become absent after coughing due to airway adapting to the presence of this. So there can be long-term effects, recurrent pneumonia, chronic cough, a lung abscess if the object's not removed. And there's a picture that shows a screw lodged in the child's left lobe. Okay, respiratory distress. About halfway through the presentation. Hang in there, guys. Respiratory distress is poor ventilation of the alveoli that results in lower than normal levels of oxygen in the blood. So, poor ventilation means O2 and CO2 are not traveling like they should through the alveoli, and in hindsight or in turn, they're going to have a decreased O2 level in the blood, which is known as hypoxemia. They'll also have an increase or higher than normal level of carbon dioxide in the blood, which is hypercapnia or hypercarbia. Same thing, used interchangeably. The manifestations we'll see most often include difficulty breathing, increased breathing rate, grunting, nasal flaring, and retractions. So I just wanted to make sure I am helping to define these terms for you. When you see hypoxia, that is lower than normal levels of oxygen in the tissues. When you see hypoxemia, that is lower than normal levels of oxygen in the blood. And when you see hypercapnia or hypercarbia, that is higher than normal levels of carbon dioxide in the blood. Visual assessment is the first step for evaluating respiratory status. Remember that grunting is a common sign in infants and it does mean severe distress. RDS generally occurs in premature newborns. It's due to lung immaturity and surfactant deficiency. The patient will exhibit distress in the form of tachypnea, retractions, nasal flaring, grunting, and cyanosis. They may have audible rales or even diminished breath sounds when auscultated. They may have what's known as seesaw respirations, and if not treated, shock can result. And a lot of these manifestations have been defined and illustrated in a video that I provided a link to. So make sure you check out that video and it will give you a visual of what we're talking about here. Our management would include surfactant administration to help improve the lung maturity, may require intubation, and may require mechanical ventilation depending on the severity. We want the child to maintain nutrition. We want them to maintain a fluid and electrolyte balance, and we want to continue to monitor their temperature and prevent other infections from occurring. ARDS is acute respiratory distress syndrome. This particular condition is often associated with some kind of lung injury. It can be sepsis, it can be pneumonia. In a newborn, it can be meconium aspiration. It could be gastric content aspiration. It can result from smoke inhalation, like in a fire, or a near drowning experience. So ARDS, the thing to remember with it is it's lung injury related from some, um, circumstance or incident. So it's an acute respiratory failure, which basically means severe hypoxemia, that is caused by lung injury that doesn't respond to supplemental O2. So it doesn't get better when you administer oxygen to the patient. Generally, it requires mechanical ventilation in order to improve oxygenation. Supportive care can include comfort measures, hygiene, positioning, nutrition, and preventing infection. If you know that amount of information about it, you will be good to go on ARDS. And then we have the worst or most severe form of distress, which is actually respiratory failure or arrest. Failure is when the body can no longer maintain effective gas exchange. It occurs due to weakened breathing muscles, and it usually manifests as a more severe form of the symptoms we discussed with distress. Respiratory arrest is when the child in distress or failure has had increasing respiratory effort over a prolonged period of time, and now the ventilatory muscles are so fatigued that the child just stops breathing altogether. That would be an arrest. So decreasing respiratory rate is a critical sign of impending arrest. We'd rather see hyperventilation than we would a low respiratory rate, because low rate means arrest is imminent. Hypoventilation is the body's need for oxygen exceeds their actual oxygen intake. Hypoxemia and hypercapnia is abnormal levels of O2 and oxygen and carbon dioxide, respectively. And hypoxia is lower than normal oxygen in the tissue. So remember those terms. Oh, things that can cause respiratory failure include serious acute or chronic respiratory or neuromuscular conditions. The compensatory measures fail. Respiratory arrest occurs. It's going to be because of increasing hypoxia that causes deterioration of the child's level of consciousness and results in a decrease of their ability to keep the airway patent. So this patient is going to require an ET tube intubation. Pneumothorax. Pneumothorax, there are three forms: open, closed, and tension, but we're just going to discuss tension on this slide and in this chapter. It is a life-threatening emergency. It is when air escapes the lungs and builds in the chest and it becomes trapped there. Generally, it's common with trauma, results in air in the pleural space. It can generally cause deviation to the trachea and decreased or absent breath sounds on one side of the body. The patient may have paradoxical breathing associated with it, and the pressure builds until eventually the lung collapse, which affects blood return to the heart and decreases cardiac output. Person's going to have chest pain, generally other signs of respiratory distress such as tachypnea, retractions, nasal flaring, and grunting. Child will need treatment in the form of thoracentesis or thoracostomy. Thoracentesis is insertion of a needle or a tube, in needle being thoracentesis, tube being thoracostomy, into the lung to reinflate the lung. So if they're receiving thoracentesis, the needle is going to go into the lung, drain the system, and reinflate the lung. If it's a thoracostomy, then they'll put in a chest tube, which will drain the system and reinflate the lung. Thoracentesis is needle through chest wall. It releases excess of fluid or air from the pleural space, and it is considered more minimally invasive. Thoracostomy is a surgical incision into the chest wall between the ribs of a chest tube and is considered more invasive, obviously. Our management of care includes airway management, monitoring lung inflation, monitoring vital signs and respiratory function, and monitoring chest tube and related complications. And there's an illustration for you of a pneumothorax. The air enters the chest and causes collapsing of the lung. When the chest tube or needle is positioned in there, it helps to allow reinflation of the lung. Let's see if it'll work while we are mid video here. I don't know what's going to happen when I click this, but let's see. Nope. You will have to watch it on your own. Do apologize. It's a clip from a movie called Just Like Heaven, one of my faves. Reese Witherspoon and Mark Ruffalo, and talks about pneumothorax and the treatment of it. And you have to just know before you watch the scene, if you're going to watch it, that in this movie, Reese Witherspoon's character is a ghost that only Mark Ruffalo's character can see. So when they're in the restaurant and the man collapses, the only person that the people are seeing is the man. He's obviously hearing and seeing Reese Witherspoon, and she is coaching him through an intervention to restore the man's breathing. And it's discovered in the end that she must be a doctor. Basically, she's forgotten who she is or what she does, and this helps her to realize that. So, cute little clip just to take your mind off of school for a moment if you want to go and watch that. Okay, now we're going to move on to chronic respiratory disorders. We're talking about things like allergic rhinitis, asthma, BPD, which is now known as CLD, cystic fibrosis, and apnea. So, all right, chronic condition like allergic rhinitis is often associated with other conditions like asthma or atopic dermatitis, which would be like eczema. It's generally a reaction to allergens such as dust mites, pet dander, molds, even cockroach antigens. It can be manifested in seasonal allergens or when seasons change. It can result from outdoor allergens like pollen, trees, weeds, fungi, or molds. And it most often exhibits watery or runny nose or nasal congestion, which a lot of students struggle with it because they're like, is it watery, runny, or is it congested? It can be either one. It can be both. It can alternate between the two. So know that it depends on the person, the allergens, and the phase in which they're in. Can also result in sneezing and itching or pruritus. The best treatment for allergic rhinitis is avoiding allergens, those triggers, if we can detect what they are and minimize exposure. Also, administering antihistamines, which would be things like Benadryl, taking anti-inflammatories, taking nasal decongestants, and other leukotriene modifiers to help tame or minimize reaction. Children might be on things like Claritin or Zyrtec or another one, but I can't think of it. Xyzal. Those are the types of meds that they may take on a daily basis to prevent flare up. Asthma. Asthma. Hopefully, this is not going to be your first exposure to asthma. In simple terms, asthma, it's the airways that are carrying air into and out of the lungs that are becoming inflamed. They swell, bronchial constriction occurs, and this obstructs airflow. It produces lots of thick mucus secretions, and it makes it hard for the patient to have effective air exchange. Here's where I was going to have you reintroduce that straw that I mentioned earlier. If you still have it nearby, take it now. Occlude your nose by putting the straw in your mouth. Take breaths in and out. Try to move something on the desk in front of you, a Kleenex, a pencil, your paper, something, so that you can experience what it's like for a patient with asthma. So before we were looking at it from the standpoint of an infant or a child's airway is very small. Now we're talking about even older children and adolescents can have this type of airway size if they're experiencing asthma, or this is what it will feel like. So hold your nose and breathe through a straw, and that's what it feels like for most asthmatic patients. They would describe the same level of difficulty and effort needed to breathe. It is considered the most common chronic respiratory disorder. It is more common in boys, usually younger than adolescents. It's also more common in low socioeconomic status families. It is believed to have a genetic component. The manifestations, I'm going to refer you back to the previous slide where we listed manifestations for lower airway disorders, and we did it for infants versus children and adolescents because that's still true of asthma. They tend to have frequent coughing, especially at nighttime. This is a warning signal. It may be the only sign you see in a patient with silent asthma. Triggers tend to be air contaminants, allergies, recurrent respiratory illness. Exercise can trigger it. Emotions and stress can as well. The patient complains of difficulty breathing. They may have an expiratory wheeze. They may have tachypnea. They're more fatigued. They may have the nasal flaring, the retractions, the chest tightness, and the increased anxiety. With asthma, how do we know if it's being controlled? This is obviously a chronic condition, a lifetime condition unless the child outgrows it. But how do we know if it's being managed well? So, first thing we can do is spirometry, which is a diagnostic measure. It's used in children that are old enough to cooperate with the equipment, usually 5 or 6 years old and older. With it, we encourage them to give their best effort each time. We tell the child to seal their lips tightly around the mouthpiece, breathe out as hard as possible, and then deep breathe in. And it's going to keep track of how effective those breaths are. Uh, Proper or controlled asthma means symptoms of 2 or fewer days a week. Nighttime awakenings are minimal, and it doesn't interfere with their normal activity like school or exercise. They shouldn't need to use their emergency meds more than 2 days a week, and they should have a peak expiratory flow rate or PEFR of 80% or greater. There should be less than 2 or no more than 1 acute episode that requires oral corticosteroids in a year's time. That's how you know asthma is being managed or controlled properly. The treatment for asthma generally involves improving their airway, breathing, and providing support. Things like medications, they generally need either inhaler or nebs or maybe something by mouth. Most children with asthma take daily inhaled corticosteroids, which is ICS, and that could be something like budesonide, which is Palmacor, or they may be on leukotriene receptor antagonists like Montlucas, which is Singulair, and those are going to be for persistent asthma, and it's not providing you quick relief, it's providing you daily control. When you need quick relief, you need something like anticholinergics or short-acting beta-2 agonists. We mentioned this in a much earlier slide. Your short-acting beta-2 agonist would be like your albuterol or your levoalbuterol, which is Xopenex, and your anticholinergics would be like ipratropium, which is Atrovent. These are used for intermittent asthma, and they are quick relief provision. If a child is less cooperative, they may require an aerosol chamber or a spacer, and this device goes between the child's face and the inhaler, and it's allowing a more easy breathing to receive the medication. You need to make sure that the child stays hydrated, and we educate on what are triggers and how can they be avoided. They need an asthma action plan so that we can know when they're in distress or it's not being managed properly, and we need to provide support for them. If a child's not able to play, active sports because it causes exacerbations, then let's give them some other activity or hobby that they can do that's less likely to interfere with their asthma. This little excerpt from your book is talking about peak expiratory flow rate or a peak expiratory flow meter. I would definitely look at this. This is giving you instructions on how to use one and how to interpret it. So you need to know what the instructions would be to the child when performing peak expiratory flow rate using a meter, and what did the results indicate. Pay attention to this slide. Okay, now we're going to talk about chronic lung disease, which is formerly known as BPD or bronchopulmonary dysplasia. This one's got some bolded numbers. Pay attention to this as a mental memory help for you. Chronic lung disease or BPD is when oxygen therapy and support for breathing is needed for 28 days or more. I'm sorry. Yeah, it is. 28 days old or older. So if it's needed past 28 days, which is a month essentially of life, and it generally is occurring in premature newborns that are less than 28 weeks old, that is going to generally be what's diagnosed as chronic lung disease, which was formerly known as BPD. So they need persistent oxygen therapy and support beyond 28 days old, and it's generally going to be in newborns that are younger than 28 weeks gestation. Infants, we know, have fewer and larger alveoli with less functional surface, area, and they have sometimes abnormal development of their capillaries. So one of the most serious chronic conditions we can see in infants is this chronic lung disease. Again, generally premature infants, so remember the number 28. It can occur in premature infants that are older than 28 weeks gestation, such as those that are younger than 32 weeks. And it is characterized based on its severity. So there can be mild, moderate, or severe forms of chronic lung disease. The symptoms or signs we see most often are increased respiratory effort. Go back to your slide where it gave you the manifestations for lower airway disorders in infants and look at what those are, the ones for infants. It could be things like tachypnea, nasal flaring, grunting, retractions, irritability, wheezing, crackles, or edema. These children are generally poor feeders. They fatigue very easily. They experience bronchospasms. They may have the barrel shape to their chest due to air trapping. They generally have cyanosis in some area, and they're generally considered failure to thrive or FTT, which means they're not gaining weight appropriately for their age. The treatment we would provide these children is supportive in trying to improve their lung function. Generally, these kids require oxygen therapy. They need anti-inflammatory inhalation medications and short-acting bronchodilators. They generally need surfactant therapy, which is to increase the lung maturity, and they need I don't know, something else in their formulas. Increased caloric formulas because they get tired so easily they're not going to eat the volume that they need, so they need to have increased calorie formulas to help make sure they're getting enough nutrition. Um, Initial treatment in BPD prone preemies may prevent development of it. That would be IV fluids as initial management, but once it develops, then they have to restrict the fluids because we don't want to have pulmonary edema present. They may need diuretics to get rid of some of the excess fluid. Continued management would also include CPT, which is chest physiotherapy. If you think of a child's back as my hand and this other hand as a cupping mechanism, it's beating on the back and trying to break up and eliminate some of those secretions. Medications, we mentioned diuretics, bronchodilators, anti-inflammatories, and caffeine. Caffeine's a very common medication treatment for chronic lung disease. They'll be on oral caffeine until some of the resolution occurs. If they have an infection alongside of the disease, the chronic condition, then they may be on an antibiotic, and it'll be important to manage those acute episodes. We want to ensure adequate nutrition. We want to promote their growth and development, know that they may be delayed, but usually their cognitive is, not too far behind schedule. It's important that we provide support for these children and their parents, and that we do discharge planning that includes care in the community that they can receive. So some of these kids have been the children that have attended Pediatrust medical needs daycare on Lake Charles. And so they're old enough to no longer need the oxygen, the caffeine, the other medications, and nursing care associated with those illnesses. Cystic fibrosis. Cystic fibrosis, I've provided you a definition that basically I got from literature, trying to put it in layman's terms, because otherwise it can kind of be overwhelming to understand. So cystic fibrosis is a disease that causes the body to make thick and sticky mucus throughout the body. It greatly affects lungs and digestive system. It's due to the buildup of that thick, sticky mucus and its side effects. It can clog the lungs, it can obstruct the pancreas, it can prevent digestion, and it's a habitat for bacteria to grow, which means most people with CF also experience frequent infections. It is an inherited autosomal recessive disorder of the exocrine glands that results in alterations in respiratory, GI, and reproductive systems. A great visual for cystic fibrosis would be the movie 5 Feet Apart. Make sure you grab tissue. But it's great to put some just images associated with the condition. Manifestations of CF include a salty taste to the skin. Don't get confused by seeing a sweet taste to the skin. It's salty in nature. Basically, it's salty sweat. They generally have salt depletion, which would mean hyponatremia. They can suffer from bowel obstruction and abdominal distension. Their stools are affected. Usually they're greasy and bulky in nature. They tend to be foul smelling and they may float in the water. These children may have physical presentation of a barrel chest due to air trapping. Their fingers may have and toes may have clubbing. They generally exhibit a chronic wet cough with wheezing, crackles, and shortness of breath, and they tend to have poor weight gain or be considered failure to thrive. They may have a vitamin deficiency, which needs correcting. And that FTT, that failure to thrive, is usually due to the body not digesting food and absorbing the nutrients appropriately. As a child gets older, reaches puberty and adolescence, they may suffer from infertility because CF can affect the reproductive system as well. So I've laid out some treatment and care in bullet form on this slide. Our main goal being maintenance of respiratory functioning. We want to provide frequent chest physiotherapy, which is that CPT, generally before meals so that they can eat without having a spell, or aspirating. Neb treatments like bronchodilators, and they may even need to wear an oscillating vest, which is very similar to CPT, but it's actually worn on the torso and it shakes and it allows those excretions to be broken up and hopefully expelled. I remember that's our goal because it can weigh the lungs down, it can make it harder to breathe, and it harbors bacteria. We want to manage infections, so they may need frequent antibiotics and anti-inflammatories. We want to promote nutrition. They are generally on supplemental vitamins and pancreatic enzymes, and they often also need fat and salt supplements. Remember, they have the hyponatremia, so they got to replenish their salt levels. We want to prevent intestinal obstruction. We want to reduce mucus accumulation. A lot of these kids will be on Robenal, which is a medication to reduce sputum viscosity, which is the thickness, and production. So it thins the sputum and it decreases production of sputum. We want to provide psychosocial support and community care. This is a chronic condition and it is considered terminal. And if the child's in need of a lung transplant, that's a possibility. But usually know that with a transplant, the body rejects it. So it only gives them minimal extension of life. Okay, so just as a recap, nursing considerations for chronic respiratory conditions. Most important thing is oxygenation. We've got to consider that. Assess and reassess the condition. Hypoxia leads to chronic changes and permanent changes in the body system. So the condition should be managed if the child has proper oxygenation of tissues. Frequency and severity of the periods of hypoxia determine the extent of lung damage, and it can result in workload required for compensation. So we want to prevent permanent damage to organs, so we want to make sure that we're always considering oxygenation for these patients. Activity intolerance, we need to keep in mind what they can capable of doing and alter it if needed. Growth and development issues are extremely important with any long-term chronic condition. Any child has to continually grow both physically and developmentally. The child's going to have increased needs for nutrition to maintain the increased workload and also for respiratory issues. So we need to try to provide that increased fluid and nutrition for the patient. Children with CF have even greater difficulty with nutrition and require specific interventions to maintain proper intake for proper growth and development. The child should be allowed to interact and play at an age-appropriate level rather than be restricted. Keep in mind the developmental aspect should be included in the plan for activity and exercise. Social isolation may be a concern with these kids. The family and child should be encouraged to participate in developmentally appropriate activities. Peer interaction is important, and having normal social interactions will allow for better emotional outcomes for the child and their family. Our treatment management is important that we coordinate with other healthcare providers and the patient's family. Collaboration is essential if we want the plan to be followed. The family should have input into the child's daily routines and schedules. We want them to be involved in planning when medications and treatments are going to be given. If we do that, that's when we're likely to get their commitment and, cooperation with it. Family input into planning and timing of treatments increases compliance. That's the word I was looking for. We need to educate on how to prevent exacerbations, when to call 911 or a healthcare provider, and the importance of medication administration. Now we're looking at apnea in infants and children. Apnea is defined as not breathing for longer than 20 seconds or any length of time associated with systemic changes, which means they become cyanotic, they may have marked pallor or paleness, may have some hypotonia, which is the weakened muscle tone, or bradycardia, which is the decreased heart rate. So cessation of breathing or respirations for longer than 20 seconds. It is not the same thing as newborn periodic breathing. So that irregular respiratory rhythm we see in infants or newborns, where they have like pauses up to 20 seconds between breaths, different from apnea or true apnea. There are different types. Apnea prematurity, or AOP, occurs in infants younger than 37 weeks gestation and is often associated with immature functioning or control of the respiratory system. It often occurs during sleep and it resolves on its own. Usually when the respiratory system matures, this condition resolves. May require caffeine therapy, which will include methylxanthines, to relax and open the bronchi. It functions very similar to a bronchodilator, the caffeine does. So basically it relaxes and opens constricted bronchi, and it stimulates easier breathing efforts for the child. This may present in the form of an acute life-threatening event, which is abbreviated ALT, ALTE, even in child or infant experiencing combination of apnea, color change, muscle tone alteration, coughing, or gagging. They make apnea monitors for this sort of thing. A child generally undergoes a polysomnography, which is a sleep study first, and then is told to wear an apnea monitor. So you see them displayed in the illustration on this slide. Monitoring for episodes, it's used at home to be worn by the child to determine the severity of the apnea. Proper positioning is necessary. Neutral or slightly extended positioning for the neck and the head being midline. Small dosage of caffeine is required, so careful titration is needed. With positive results from sleep study, the patient would require the monitor and possible pulse ox monitor as well, with an event recorder to be worn at home. The parents will be instructed on keeping a log of the alarms, determining frequency and possible triggers for the patient. When you're performing a respiratory assessment, it's important to use these guidelines for the child in distress. Make sure your assessment includes the quality of pulse. Is it weak? Is it normal? Is it fast? Is it regular? The quality of respirations. What's the speed, the rate, and the rhythm? Is there any accessory muscle use? What's the color? Is the patient mottled or cyanotic? Is their cough productive or persistent? Does it indicate a foreign body presence? What are the patient's behavior changes? Are they having mood or level of consciousness changes? Are they in a stupor? Are they lethargic or severely irritable? Are they showing any signs of dehydration? Pulmonary edema, shock would be indicators of that. When assessing the respiratory status, it's important to note the following to help determine the severity. And that's what we're talking about here, is being able to identify the severity of the patient's respiratory status. We mentioned retractions much earlier in the different types. This is now an illustration showing you where they occur in the body. So supraclavicular and suprasternal. Remember, supra is the medical terminology for above or on top. So it's happening above the clavicle and above the sternum. Intercostal, inter meaning within, is happening between ribs. And substernal and subcostal, sub meaning below, and it's happening therefore below the sternum or below the ribs. So make sure you remember these different types and their location. This is a video I was referencing. It's in the slide. It's also on the Moodle page under, the collapsible topic for this content. So you would want to check this out so that you have a better understanding of what we've been talking about. It's going to show you some examples of a lot of these distress signs in children. We need to not forget laboratory and diagnostic tests that are used for determining disorders in the respiratory system, and that would include things like pulse oximetry would tell us their pulse saturation, O2 saturation. We'd look at their chest radiograph, which would be x-rays. We'd look at blood gases or ABGs and PFTs or pulmonary function tests or studies. When you obtain a pulse oximetry reading in an arterial blood glass, you're getting a transcutaneous estimate of the hemoglobin saturated by oxygen, or the SpO2. It's expressed as a percentage of hemoglobin capable of transporting oxygen. When you assess oxygenation or O2 in the body, it's also important that you determine ventilation. So ventilation is the exchange of air between lungs and atmosphere. Oxygen is absorbed and carbon dioxide is eliminated. When you're failing to detect hypercapnia or hypercarbia or problems of poor oxygen delivery, the patient may be anemic or have low cardiac output. And it's saying that, O2 saturation doesn't give you that information. It's only determined when you obtain an arterial blood gas or an ABG. Radiograph findings can indicate the cause of the problems, like epiglottitis, meconium aspiration syndrome, or pneumonia. ABGs and pulse oximetry are considered diagnostic tests to determine oxygen saturation. ABGs assist in the interpretation of acidosis and alkalosis and is considered with simultaneous assessment of oxygenation status. When the patient's in acidosis, hypercarbia is going to be present. Hypoxemia, which is the decreased O2 in the blood, is going to happen when the body's not responsive to supplemental oxygen. And then PFTs or pulmonary function tests or studies may be completed, such as FVC, forced vital capacity, PEFR, the peak expiratory flow rate, and FEV, which is forced expiratory volume. These can occur or be tested in a lot of the chronic respiratory conditions. So what does the nursing management or care look like with these patients? Nursing care should focus on determining the cause and alleviating it if possible. So if it's a foreign body or object in the throat, we need to get it out. We need to focus on ABCs, airway, breathing, and circulation. Maintain an adequate form of all three. Consider interventions like removal of the foreign body, provide supplemental oxygen, provide supportive care. Consider extreme measures if needed. Do they need to be intubated? Do they need an ET tube? Do they need mechanical ventilation like a ventilator? Do they need a tracheostomy, which is a surgical opening in the trachea through the neck? Are they going to need a CPAP? Are they going to need continuous positive airway pressure, which is what CPAP stands for? One form of PEEP is used to improve oxygenation and lung compliance. PEEP being the positive end expiratory pressure, which increases functional residual capacity. Do they need ECMO? ECMO is the extracorporeal membrane oxygenation. It's an advanced life support. It uses a bypass machine for the heart and lungs, and it's providing rest and healing for those organs. It provides respiratory and hemodynamic support while the lungs and heart rest and heal. ECMO is definitely an indicator of a severe condition, and it's not always recoverable. So now we're going to talk about the common medical treatments for respiratory disorders in general. Just want to recap that those interventions include oxygen administration, high humidity or humidification, suctioning when there's excess mucus, CPT, which is chest physiotherapy and postural drainage, may even include an oscillating vest, saline gargles or lavage when it's talking about the throat and discomfort there, mucolytic agents, which are going to help to decrease the mucus production, like Robenal, chest tubes if we have a collapsed lung and we need to reinflate it, and bronchoscopy, which is going to allow you to view the bronchial system or the bronchial tree and see what's going on. Supplemental oxygen. This is something we've talked about with most of these conditions so far. It is indicated anytime the child's SpO2 level is less than 92%. Interventions are individualized to the patient, and you have to consider their medical history before intervening. So we need to be able to monitor their pulse ox and blood gases, provide humidified oxygen if needed. Let's talk about a sickle cell patient just for a moment. A patient with sickle cell is going to average a lower oxygen saturation than a non-sickle cell patient. That's just because of the condition of their body. They have sickled red blood cells. They're not going to have as high of O2 saturation. So we need to consider that when determining what is a concerning level and requiring intervention. Ventilated and tracheostomy patients usually average a higher O2 level because they're already receiving assistance. So we need to be monitoring it and more alarmed when it drops even just a little bit, because we know that they should be able to maintain a higher average reading because of their assistance they're getting from these devices. Delivery methods vary. You know that oxygen can be given through a nasal cannula. That's used when a low flow or low percentage is needed, usually between 1 and 6 liters. If you want higher flow or higher percentage of oxygen delivery, we need to think about a face mask. This can be used to deliver between 6 and 10 liters of oxygen per minute. If we need the highest flow and the highest percentage, we need to be looking at a non-rebreather mask, and that can deliver up to 15 liters per minute of oxygen. Know that the Venturi mask is unique and used often when we're trying to get a very titrated oxygen for precise O2 delivery. This will be helpful in minimizing the risk of carbon dioxide retention, and it's important in patients with conditions like COPD. Got an illustration on this slide for you of the placement of a pulse ox probe on a child. Remember these important tips. Place the light emitter portion of the probe on the top of the hand, foot, or finger. The light must be able to pass through the skin, so it should be directly opposite the photodetector of the probe, and that's what's going to allow you an accurate reading. For infants, the best sites to place the probe would be on the palm of the hand or on the foot of the child. Tracheostomy, we've mentioned this a few times now throughout the PowerPoint, but let's go into it a little more in depth as to what it is and what function it serves. Tracheostomy is an artificial opening in the airway. It's intended to maintain patency. This medical device generally is going to prevent vocal cord vibration, and therefore the child cannot cry or talk when a tracheostomy is in place. Their function is to facilitate secretion removal reduce work of breathing, increase child's comfort, and basically maintain patent airway. They can be permanent or temporary. Know that danger associated with tracheostomies is they can become occluded with the mucus plug. So sometimes children have the developing or um, storing of secretions that then get dried out and it kind of hardens and it creates this plug in the airway and air has to try to get around it. So that's why frequent suctioning is recommended. Saline to the trachea is recommended to try to keep those secretions moist and liquefied so they do not cause a plug and obstruct the child's airway. Children that are requiring a tracheostomy are going to require comfort, and the family is going to need support because of anxiety, fear, and frustration. We need to be mindful that the tracheostomy can become dislodged, and if it gets removed from the airway, then it's not serving its purpose anymore, which means the child's O2 saturation is going to drop and their airway is going to be compromised. So this needs careful monitoring. Children that have a tracheostomy are going to need an alternative form of communication. You need a different way for them to be able to make noise to tell you that they need you. That might include hitting a bedside table or the bed rail. It may require a communication board or a call light, depending on the child's age, cognitive function, and cooperation level. Tracheostomy ties will be changed daily to minimize skin breakdown and ensure proper hygiene. Trach care is often performed throughout the day, usually 1 or 3 times, which would mean suctioning and cleansing the external portion of the trach. Suction secretions as needed, provide trach care and skin care, perform CPT if needed. Trach tubes are removed and replaced on a regular basis, so cleaning can be performed. Usually that's weekly for kids. So you take out the dirty one and you immediately put in a replacement so that then that dirty one can be cleaned and reused the following week. Children that have a trach also should have what's called a go bag. This is basically a bag of essentials. It contains all the things that would be needed for replacing the trach, removing a plug, anything like that. So things like same size trach, one size smaller. Think about why that would be important. If you were to have a situation where the trach became dislodged or you needed to pull it out to replace it and you couldn't get the same size in because that stoma is either swollen or narrowing, you need to have a trach size that's a size smaller so that it can be put back in because you don't want them to be without a trach for any length of time. Suction equipment, lubricating jelly, trach ties, scissors, all of these things would be part of the child's go bag, and that goes with them wherever they go. Keep in mind interventions that are going to minimize psychosocial impact of these chronic conditions involving the respiratory system. We want to do whatever we can to promote the child's self-esteem through education and support. We want to allow the child to be involved in their care, take control and management of their disease if they can do so. We want to promote family coping through education and encouragement. And we want to be culturally sensitive, provide interventions that do so for these families as well. And this would be the time in class when I would ask for any questions, if there's anything that's confusing or needs clarification. Did you miss something? Do you need to comment? Obviously, you can do so through the social forum we have on Moodle or send me an email if that would be preferred. We're going to look now at a couple of application questions just to kind of review the content and give you some practice in applying what you've learned in this PowerPoint. So the parents of a child who had a tonsillectomy 3 days ago are calling about concerns with symptoms they're seeing. Which symptom would alert the nurse that the child may be having a post-op problem or complication? Is it A, the child has white crust on the back of their throat? Is it B, the child is having increased swallowing? Is it C, the child will only eat popsicles? Or is it D, the child complains of throat pain? We got to go back to the question stem and see what's important information. The child had a tonsillectomy, which is removal of the tonsils 3 days ago. So some of these symptoms we would expect, and they would not be considered a post-op complication. They would be considered an expected finding. For example, throat pain. If you just did operation or surgery on my throat, I'm probably going to be in pain 3 days later. I'm probably going to have crust in the back of my throat because of scarring and healing, and that's expected. And I'm probably going to want to eat only popsicles. Now, that might concern you because that may not seem like that's nutritionally, adequate. But what really should stick out to you is what? Letter B. The child's having increased swallowing. What did we say in this content was generally an indication if they were having increased swallowing? Hemorrhage or bleeding. That would be a concern. Maybe it's this incision is open and bleeding a lot. We'd want to get that looked at. So the answer for this question is B, the child is having increased swallowing. Number 2, the nurse is caring for an infant who was admitted to the hospital for the treatment of RSV bronchiolitis. What assessment item would the nurse report immediately to the healthcare provider? So our options are increased temp, increased heart rate, decreased pulse ox saturation, and decreased bowel sounds. So when we're looking at this patient, we're thinking of respiratory functioning. What are we going to report immediately if we come across it with this patient? Would we expect that they would have a temp? Probably they're experiencing an infection. Would their heart rate be increased? If they're having trouble breathing, if they have an infection in the body, then probably so. Would we expect them to have decreased bowel sounds? Generally, this does not have association with the GI system, so that would not be likely, which means if it does happen, it might be a concern. But what is your most concerning thing? The decreased pulse oximeter saturations. We want to address the patient that's having a decrease in their pulse ox. The neonatal nurse is giving discharge instructions to the parents of an infant diagnosed with BPD, which is what we're also now referring to as chronic lung disease. Teaching was ineffective if which statement is made by one of the parents. So you're looking for a statement or an answer choice that is not true. If it's asking for what's an indication that teaching was ineffective, then the statement we're looking for is a non-true statement. So let's look at all four. A, I can expect my baby to require diuretic therapy. Hopefully that's sticking out as a memorable intervention. They may need diuretics for the excessive mucus in their lungs. I can expect my baby to be on oxygen therapy for the rest of his life. We do remember oxygen therapy being needed for these children, but I don't remember anything about it being forever. I can expect my baby to receive respiratory treatments at least once daily. Based on the chronic nature of this condition, it probably would be necessary to give them some kind of treatment, maybe neb or medication on a daily basis for these kids. I can expect to come to the office more during winter months for at least the first year of life. And based on what we've learned, obviously the winter months are hardest on a child with compromised respiratory functioning, so that seems pretty logical. What I would like to caution or really encourage you to look at if you're struggling with the process of elimination is which of these, if any, has an absolute to it. Always, never, constantly, forever. Which of these has that verbiage? Usually that's going to be the answer that's going to stick out. If we're talking about ineffective, it's probably the one you want to choose. If we're talking about things that are expected, it's probably the one you want to avoid because every person's different and you can't say for sure that what's the case for one is going to be the case for another patient with the same condition or disease. So I should be leaning towards B. I can expect my baby to be on oxygen therapy for the rest of his life just because that absolute nature is just not true in most medicine. So we're going to click and see. And yes, B is the correct answer for this question. And the last question, the nurse is caring for a child with cystic fibrosis. Which of the following treatments would be used to promote mucus clearance through percussion or vibration? So this just boils down to a knowledge question. Do you know what suctioning, a chest tube, bronchoscopy, and chest physiotherapy are, and what are they used for? and hopefully you're going to recognize CBT or chest physiotherapy as the treatment that is using percussion or vibration to promote mucus clearance. If you did pretty well on these, that's a good indication that you paid attention during this PowerPoint and you retained a lot of the information. If you didn't, you need to go back to the slides about those particular conditions and likely the whole presentation if you really weren't getting it. Make sure to do Prep U, Chapter 18. It is being taken as an assignment grade, but it's also intended to help you review this content and make you prepared for the test on Monday. And then tune in at 1 o'clock when we get online and do a Q&A Zoom. We're going to do some application of content through critical thinking exercises and possible, test question format. So I hope you got something out of this.